I hope you're all safe and sound and all motivated with all the energy, with all the enthusiasm, and you are ready to study internal medicine with me as you have been over the last 6 days. Okay? So today is the day 7th of studying nephrology with me, and I hope that you all have formed good and concepts of medicine. Yeah. So now I also have logged into the e-medicos and I can see that you all are already replying and you're already the Josh seems to be high. Superb. And the very, very mandatory, please tell me, how's the Josh? Very high, sir. How's the Josh? Unbreakable, sir. How's the Josh? Sky high, sir. That's the way, guys. If the Josh is this high, nothing can stop us from doing what we want to. Okay? And as always, let me begin today's class with the motivation, and let me quote for you the most famous shlok of Bhagavad Gita, and I let me please at the very outset detach the religion part from it. I have already told you in the beginning that I do not consider Bhagavad Gita as a religious book. I consider it to be a motivational book which was actually recited some 5,000 years back by Krishna, and that was not only for Arjuna, that was for all of us. And any doubt if you have, let me tell you, it is absolute, the solution is there. And any motivational book, be it international, be it local, that has been made, it cannot have been made without taking inputs from this book. So it is the master or the universal motivational book. And the most famous shloka, which is basically in the verse 47 of chapter 2, that says, when Krishna says to Arjuna, he says that karmanye vadika raste ma faleshu kadachana ma karma fala hetur burmate karmot swakarmani. This is the shloka that I try to recite almost daily when I get up and when I set out to work, and I tell to myself that you, Vivek, you only are entitled to the karma. You are only entitled to the work part. You should be detached from the fruit part of it. If our main motivation is just to do the work, that is the best form of karma. If we are guided by the fruit or by the result of it, let me tell you, that shall not be the ideal karma. And if you are just being lured by the fruit of it or by the result of it, your karma shall not be wholehearted and 100%. So basically, just put your 100% in whatever you do, and do not try to over contemplate or over think or over prophesize the result part of it. When you detach the result from a work or from a job that you do, that job becomes 100% pure in its form, and it will be delegated. It will be the commitment that it will be showing that will be absolutely incredible. So basically, please, right now what I mean to say is, do not think about the result of your NEET and next PG. No. Right now, just enjoy the preparatory phase. Your focus must be that I shall do my best and leave the rest. If you do your karma, that is to study and prepare right now with this mentality, let me tell you, nobody can stop you. Is it clear? And of course, I cannot forget the greatest teacher who has ever lived, according to me, was Dr. APJ Abdul Kalam, the ex-president of the country. And he said that if you want to leave your footprints on the sands of time, do not drag your feet. It always crosses my mind. There's an English word known as legacy. And whenever I'm alone, right now I'm alone, I'm living away from my family. I've sent my family back home because, I'm dealing with COVID patients day in and day out. So the worst thing I want to do is, be a carrier and transmit COVID to anyone who's near and dear to me. So, I often get, alone time, and I think and contemplate. And the only thing that, sometimes that gives jitters to me personally, I'm sharing with you all, considering you all are my younger brothers and sisters, that, what about my legacy? What do I want to leave behind me? Because, we all are mortals, and one day we all shall pass. And what shall remain is legacy. And I just do not want to be remembered, or I just do not want that one day, one fine day in the cremation, during the cremation, some people utter that, yeah, Dr. Vivek Goel, अच्छे आदमी थे. That is a very single sentence, one tries to sum up a total life into. But, I want to leave something more. So, that is why. So if you want to leave your footprints on the sands of time, do not drag your feet. Raise your feet as high as you can. Try to walk as fast, and in my words, try to run as fast. Okay? Because time is limited. Time is limited. I am not saying that do not enjoy time. Enjoy time. But try to do as much possible. I had read a Hindi shairi where, it said, and I totally related to it, जिंदगी भले ही आम हो, जिंदगी भले ही आम हो, मौत मुझे मशहूर चाहिए. So, don't misunderstand the essence of it. What I was trying to say is, there were many people who lived absolutely a normal life when they were living. But after their death or during their death, people realize how great they were. And the legacy that they have left is beyond the, constraints of time, religion, barrier, or country, or whatever. So, try to do as much as possible in your limited lifespan, whatever years the Almighty has given to us. We shall try to put as much into it. Okay? So, too much of philosophy today? Too much of philosophy? But never mind. Now, never mind. Let's lighten up. I just got a bit flown away. I am very, some people might be thinking, kya ho gaya sir ko? What has happened to sir? Why is he talking like this? I was just, it's just the fault of these times, because, care. Let's leave that. So, coming back to nephrology, come on, gather yourself. Take a deep breath. Come on, students, let's come back to nephrology. And yes, I had left a few questions yesterday, which I think you want to discuss it today only. I think you want to discuss today. Yes, you want to discuss it. Okay. Let me discuss a few questions with you before I begin with today's class. And the very first questions that the very first question is an AIMS question, not my question strictly, but I've discussed it. The most specific sign of metabolic encephalopathy. I told you metabolic encephalopathy, it could be hepatic, it could be uremic, it could be CO2 narcosis, and yes, it is asterixis or the flapping tremor, which is a kind of what movement disorder? Come on, tell me in chorus. It is a dash. I want the answer. All of you to type the answer. I am waiting for the answer. You are absolutely correct, sir. It is a negative myoclonus. It is not a tremor. Very good. Coming to a question asked by Jipmer in 2018. Till then, this molecule, it was left in the corner in the Harrison's textbook. Nobody was asking it. Nobody was giving it importance. But Jipmer suddenly, diverted the attentions to FGF23. Oh my God, this is such a potent MCQ. In Tushar sir's words, MCQ hua hai. Many of you have been saying that sentence again and again. I have also learned that. So, what is about FGF23? That is not true. It increases phosphate excretion. I gave you 6 MCQ points yesterday about FGF23. It's a phosphatonin, so it increases phosphate excretion. Absolutely true. It has direct action on the renal tubules. Of course, it has action on the proximal convoluted tubules. Tabhi to it will excrete phosphate. It acts on the sodium phosphate co-transport just like parathormone, and it causes phosphate excretion. It inhibits 1-alpha hydroxylase. Yes. You remember my yellow arrow? My yellow arrow went up and inhibited the vitamin D3 form, the calcitriol formation. You remember? Yes, sir. So it inhibits vitamin calcitriol and thus inhibits calcium absorption. This is also true. It increases absorption of phosphate. No, sir. The one who is a phosphatidylcholine, how can it cause increased phosphate absorption, sir? It will cause decreased phosphate. Okay, sir. So answer is C. Now, a PGI Chandigarh question. Which of the following favors a diagnosis of chronic renal failure rather than acute renal failure? I told you yesterday, renal osteodystrophy of course goes more in favor of chronic renal failure. Raised creatinine level can occur in both. Sir, acute kidney injury में भी raised होगा, CKD में भी raised होगा. Small kidney will never occur in AKI. It always will occur in chronic kidney disease. Peripheral neuropathy will always occur in chronic kidney disease, never in acute kidney injury. So answer is B, D, E. Now regarding anemia, most of you might be thinking, sir, anemia also is a feature of CKD. Absolutely true. But anemia can be a feature of acute kidney injury also, because anemia can happen within a span of few days. If due to any reason it could be dilutional in acute kidney injury. It could be dilutional, it could be, the uremia also can cause anemia, the blood loss due to the causes of AKI can cause anemia. So anemia is not a very, very specific feature of CKD. But B, D and E are very, very specific features. Is it clear? Is it clear? So if you would have appeared for PGI Chandigarh right now, you would have got 3 marks from one question. Now, tell me this answer. Tell me this answer. Which of the following are of importance in a patient of chronic kidney disease? Which of the following are of importance in a patient of chronic kidney disease? Is it BP control? BP control do you do in CKD? Of course, yes, sir. How will I not, sir? Drug of choice, ACE inhibitor, ARB. Sugar control. Yes, sir. Remember Sharma ji? Remember Sharma ji? He himself got sugar control by paradoxical improvement of diabetes mellitus. Low salt intake. Is salt intake should be low? Yes, sir. Of course, I'll tell you how much salt to be taken. Otherwise, you will develop volume overload and increase in BP. Peritoneal dialysis. Dialysis must be done in CKD. Sir, without dialysis, nephrologist is crippled. And ACE inhibitor ARB, of course. So let me tell you, I think this was the toughest question in the history of PGI Chandigarh, where even if you knew very little of nephrology, you would have got 5 marks. This was a sitter. Not getting 5 in this question would have been a crime according to me. It would have meant a crime according to me. Okay. I will come to this. Now tell me this question. The KDIGO CKD classification, remember classification, GFR, albuminuria and all that, depends on all except, I told you the classification is also known as a GCA classification. Sir, G for GFR, C for cause and A for albuminuria. But sir, what is not there is hypertension. Hypertension, sir, is not there at all. So answer is A. It is a GCA classification. Very good. Very good. And with this, we come to the end of today's the opening session of questions, and the remaining we shall discuss it in subsequent time. Now let us begin. Let us begin with where we had discontinued yesterday, and I think the last thing that we studied yesterday was the vascular feature, that was calcific uremic arteriolopathy. I think I am correct. The next feature that we shall be studying today is the gastrointestinal tract feature, and of course what is very important is if you have ever gone near a patient of advanced chronic kidney disease, if you have ever gone near to a patient, you will feel a beautiful aroma coming out from his mouth. You will feel a beautiful aroma coming out from his mouth, and that aroma is that of urine. That is why this is known as uremic fetor. That is known as uremic fetor. Just like a CLD patient has fetor hepaticus, the smell of stool. A CKD patient has a typical uremic fetor coming out from his mouth. Next, that is why we nephrologists, we understand the degree of uremia. If the patient comes too close to us and he talks and he opens his mouth, we get to know that this patient is very, very imminent for dialysis just by the amazing aroma he exhales from his mouth. Okay, and at that point of time, you can't even tell him ki have a Mentos. Care. What else? You can also have, definitely a patient of CKD is very predisposed to malnutrition. Okay, so a patient of mine came to me. I told him, "Arey Sharma ji, you are so thin, sir. You have lost so much of weight, sir." I told him. He told me. He got angry. He told, "Sir, first of all, sir, I don't feel hungry at all. I am so anorexic. I don't feel like eating. On top of that, sir, you have created 1,000 restrictions. Don't eat fruits. Don't eat this. Don't eat that. I have low protein and whatnot. And sir, then you are telling me I am losing weight. What do you expect me to do, sir? You're not allowing me to eat some food only." I was like, okay. Take a chill pill. Take a chill. And then I told him, "Sharma ji, don't worry. I'll start you on dialysis. Once I start you on dialysis, life will be normal. Eat as much as you can. Eat whatever you want to do." And Salman Khan's words, do whatever you want to do, man. Okay. And last but not the least, peptic ulcer disease. Peptic ulcer disease. Is it clear? So it could be uremic fetor, malnutrition, peptic ulcer disease. Okay, after GIT, coming to the last system of, last manifestation of CKD, coming to acid base and water fluid electrolyte. So in the acid base system, I'm forgetting the numbers. Probably it was till 7 yesterday. Probably. Please correct me if I am wrong. This will be number 8. This will be number 9. Coming to acid-base balance, what will you get? In acid-base balance, you will get something known as metabolic acidosis. Why, sir? Because, sir, there will be impaired excretion, and so there will be piling up of acids also. And ultimately, sir, the acidosis, I told you, metabolic acidosis is always divided into two. That is high anion gap and normal anion gap. So it will be high anion gap. High anion gap se yaad aaya. Sir, you taught me one disease which had a normal anion gap metabolic acidosis. Please tell me the answer quickly. Yes, sir. The answer is yes, of course. Renal tubular acidosis. Renal tubular acidosis. So this will be HAGMA. And NAGMA, I taught you one disease already. So you will get HAGMA. Sir, how will I treat HAGMA, sir? Of course, sir. I will check for the bicarbonate. If the serum bicarbonate will be less than 22 milli equivalents per liter, I will start the patient on sodium bicarbonate tablets. I'll start the patient on sodium bicarbonate tablets, and of course, once a patient is on dialysis, so I will need not put him on this tablet, because now the dialysis will do the work of removing the acid material and the uremic toxins. Is it clear? So when the serum bicarbonate is less than 22, you will start sodium bicarbonate tablets. And the last system is fluid and electrolyte. I intend to teach you electrolytes tomorrow in details. Because I know that many of you have, requested me over time that, sir, electrolytes are very neglected, sir. And let me tell you, electrolytes, at least one question comes every year in AIMS from electrolytes, and 2 or 3 questions comes in All India, NEET or NEXT from electrolytes. And if you happen or intend to appear for any foreign examination, do not sit in the exam. Do not go to, fill the paper of the question, fill the admission paper of the exam without studying electrolytes. It is so damn important. It is so damn important. So tomorrow I intend to teach you electrolytes. Okay? So in fluid and electrolyte, what will you get? I will get hypervolemia. I will get hyponatremia. A student I see has been repeatedly answering, sir, why will uremic frost will not be a manifestation? Krishna P. Deshmukh, yeah, uremic frost is also a skin manifestation. Please let me first clarify one point. I cannot teach you nephrology, entire nephrology in 14 hours. Let me tell you. Some people were telling me, sir, this cause is written in Robbins in minimal chain disease. You have not made us write. Why, sir? Can I make you write the entire Robbins, the entire Ganong, the entire Harrison, and the entire Brenner's, which I also intend to in a few parts of nephrology portions, in 14 hours? Absolutely not possible. So I am not giving you the exact text material, the universal set. No. I am giving you the important points which can A, build your concepts, B, it can cover maximum part of your text also, and C, help you solve all your MCQs. So you must understand the purpose why we are doing here. If I were to only give you text and information, I would not have been here, because you already have so much. So do not ask rhetorical questions, okay? Okay? Do not worry, I am there for you, and I will not leave anything which is, there's a remotest possibility of being asked in the exam, according to my discretion and my understanding of the exam. And I think you can trust me. Yes or not? If yes, give me a love wala smiley, quickly. Clear? Last but not the least, there is hyperkalemia. There is hyperkalemia. There is, of course, hypervolemia. Hyper. Clear? So these are the very good. Thank you so much for showing trust in me. Thank you so much for showing trust in me. Now very quickly, why does a patient develop hyponatremia in CKD? It is usually the dilutional hyponatremia. What do you mean by that, sir? Usually the total body water. It is usually the dilutional hyponatremia in chronic kidney disease patients. So basically the water is, the sodium content may be normal, but the water increases so much that it causes a hyponatremia. Is it clear? And these are the what a person was saying. Anudeep is saying we need communication skills. Listen, Anudeep, I am myself trying to learn communication. Is it clear? I am also a very amateur and very a naive person when it comes to communication. Communication skill is a very big art, and we all are cumulatively trying to learn it. Okay, why does hyperkalemia develop in CKD? Hyperkalemia develops in CKD because of low GFR. Number 1, from dietary protein. Number 3, it develops from ACE inhibitor ARB. ACE inhibitors and ARB, because that is a drug of choice to treat hypertension in CKD. Yes or no? And of course, it can develop due to these many causes. There are many, but these are very, very important. These are very, very important. Is it clear? Absolutely clear. So these are the metabolic, I mean the fluid electrolyte disturbances that occur in CKD. Of course, the rest of it I have already taught you before. Now, you know, hyperkalemia is a very, very common, notorious manifestation. We often say to patients, please avoid fruits, please avoid citrus fruits, please avoid potato, potassium-rich foods. You know, we tell them a lot of things, and you know, but patients barely adhere to what you will say. They will ask you 1 lakh questions, but I don't know how will they, you know, but they rarely adhere to you. So I still remember, I was, you know, in my second year residency, and a patient had come to me. He was a patient of CKD3. He had a creatinine of around 2 mg per dl, and he had a slight hyperkalemia. So he was having a hyperkalemia of say 5.8, 5.9 milliequivalents per liter. So I will teach you how to manage it. So basically I told him restrict potassium, and I gave him potassium binding resins. The second day I came on the ward rounds, I checked the reports. Again, it was 5.7 milliequivalent per liter. I thought, why has it not decreased subsequently? I told him, are you taking those sachets? He said, yes sir, absolutely sir, ekdam sir, bilkul sir, aap jo bole wo sir. I'm like, okay. I thought, now if I don't control the potassium, that till the next day, my mentor will beat me up. My guide will beat the hell out of me. So you know, the next day I came and I was hoping that the potassium will come around 5. And to my surprise, the potassium came to 5.9 milliequivalent per liter. Now I got paranoid. Now I thought, what the hell is this? Now what does one do? I shouted on the nurse. I told him, sister, what is this? Why is the potassium not getting controlled? Why are you not giving those sachets? Give me your register where you have shown the tick mark that you have given the potassium binding sachet to him. He is like, she told me, yes sir, I have given. I was like, okay. I asked him, are you taking? He was also okay. He was like, yes sir, I am taking the sachet sir. I am absolutely ardent follower of whatever you are saying sir. I thought, do I not know the management of hyperkalemia? I went to, you know, the window, the casement, and I opened my Harrison's in my phone. And you know, in my smartphone, I was opened the Harrison, I was trying to read hyperkalemia. What have I missed? What am I doing wrong? And suddenly, I saw a person walking like this in the medicine wards. He was walking like this, and he was walking in slow motion. And as he came nearer to me, a smirk immediately appeared on my face, and I was, you know, smiling at myself. And you know, he came to me with 2 things in his hands, and I told him, beta, what is this? What is this for? You know, the typical Indian mentality, they will never consume one thing on earth when they are fine, but they think that there is only one thing which can cure them during hospitalization, and you know what that is? Especially the people down south, that is coconut water, that is nariyal pani, and he had 2 nariyal panis like this, and I asked him, beta, who is this for? He said, for daddy. I asked daddy, how much do you consume? Sir, I take 3 in a day, sir. I was like, okay. If you continue to take this nariyal pani, God forbid, I wish you are not transmitted vertically, and then you will never be able to consume nariyal pani. So I told him, I requested him, sir, please, हाथ जोड़ के विनती आपसे, please do not take nariyal pani. It is absolutely a poison for you, because if you develop hyperkalemia, do not tell me if you suddenly develop a VT, VF and a cardiac arrest, sir. Please sir, please do not take it, and please refrain from potassium foods. Then I gave him a detailed diet chart of what to have and what not to have, and of course I did that for my own benefit, my own satisfaction. I knew he barely, you know, followed it. So this is the real life story. Whatever you know, tell or profess or teach patients, they do whatever they want to do, man. Okay. So with this, we have completed all the features of CKD, and let me just increase the temperature of the AC. I'm feeling a bit cold. All right. So now let us enter into the treatment of CKD. Let us now enter into the treatment of CKD. How do you treat CKD? The treatment of CKD is in one phrase, renal replacement therapy. Renal replacement therapy, and renal replacement therapy basically comprises of two things. One is dialysis and one is transplant. Obviously, transplant is the best treatment of chronic kidney disease, and that too if you get a live related kidney allograft transplant, that is the best. And out after the live related kidney transplant, you can also do the cadaveric transplant, but the best is the renal transplant, better than dialysis. Now, if I ask you what are the absolute indications of dialysis, then you will tell me, sir, you have already taught me a few. And those indications are: number one, the indications, absolute indications of dialysis are number one, uremic. Do you remember uremic encephalopathy? Number two, sir, CKD patient coming to a what? Coming with what? Chest pain, ECG changes, can be painless, can be hemorrhagic. You put a stethoscope, you get a pericardial rub. Of course, you will get a uremic pericarditis. Number three, if you get a refractory hyperkalemia, if you get a refractory fluid overload, so if you get a refractory hyperkalemia, if you get a refractory fluid overload, and last but not the least, if you get a refractory metabolic acidosis, So today only I saw a patient, young 21-year-old male. He came to me with a lot of uremic symptoms. He was vomiting, he was anorexic, he was weak, he was dyspneic. Every doctor he had met before had prescribed him dialysis, but he was hell bent that anything I will do, but I will not do dialysis. And while I was talking to him, he threw up a seizure. So basically, he had a uremic encephalopathy manifested in the form of a seizure. And when he had a seizure, I drew an ABG, and ABG showed a severe metabolic acidosis, pH of 6.96. I started him on antiepileptics, and I started him on soda bicarbonate infusion, and I told his parent that, listen, now if you do late, it will be too late. Please tell me what to do. They were still thinking and contemplating. Then I strongly made them write a high risk consent if they do not allow for dialysis. And reading that, they understood that I'm going to lose my 21-year-old son, and then they allowed dialysis. And finally I had to start him on dialysis, because despite 2 hours of soda bicarbonate infusion, his metabolic acidosis was not resolving at all. He was having severe metabolic acidosis. Is it clear? He had a generalized tonic-clonic conversion. You do know usually metabolic reasons usually cause a generalized seizure. You must have read it in neurology as well. Okay? Some people were like, sir, do all CKD patients want dialysis? Of course not. Of course not. You basically, let me just modify this algorithm for you. Let me just modify this algorithm for you. So CKD patients usually in stages 1 to 4 or stage 5, that is known as end stage renal disease. So the first 4 stages are usually treated conservatively, and the fifth stage usually the person requires dialysis. I hope now I am making some sense to you. So you basically go for renal replacement therapy in the final stage or the CKD 5 stage or end stage renal disease when the GFR drops to below 15 ml per minute per 1.73 meter square body surface area. So till then you are just treating the complications, till whatever we have taught. Skin may you are giving that, for calcium phosphate you are giving that, you're treating anemia, you're giving sodium bicarbonate, you're restricting salt in diet and stuff like that. This is how you treat the patient. Clear? But these are absolute indications of dialysis which are actually irrespective of the stage he is in. Any stage of CKD, a person presents with these, of course normally presents in CKD 5 only, you have to go for dialysis. And these are the 5. Who said I didn't teach you the staging? I taught you the staging. That was the KDIGO staging, G1, G2, G3, G4 and G5. I taught you yesterday. So this is the renal replacement therapy. These are the absolute indications of dialysis. I hope I am clear. And ESRD means end stage renal disease. End stage renal disease. Okay? Is it clear? Absolutely clear? Any doubt yet? Now, so we will study dialysis now, and I taught you dialysis can be of 2 modalities. One is hemodialysis and one is peritoneal dialysis. I will teach you what is that. You asking me what was my patient? My patient, 21-year-old CKD, he was a case of, he had a posterior urethral valve, which was a congenital deformity. Though he got corrected, he was having a lot of vesico-ureteric reflux. And that vesico-ureteric reflux led down to scarring of the kidneys, recurrent UTI and caused CKD. Okay? So, this is hemodialysis, this is peritoneal dialysis. I'll teach you the principle of both. But let me tell you the basic difference between the two. What is the basic difference between the two? Now, the hemodynamic shift. The hemodynamic shift is here in hemodialysis is too large, while in peritoneal dialysis is mild to moderate. I will tell you the principle, do not worry. Then number 2, the pace. Here the pace is fast, it is slow. That is why it is an intermittent process, whereas peritoneal dialysis is a continuous process. Write down, I will tell you what am I saying. This can be done at home, while hemodialysis you need to come to a hospital facility. Complications. Complications in hemodialysis are less. In peritoneal dialysis, they are more. I mean, in comparison to each other. Okay. Otherwise, isolatedly, hemodialysis also has a lot of complications. Now, can you dialyze a hemodynamically unstable patient? Can you do a hemodialysis? No, but you can do a peritoneal dialysis. Please understand what I am trying to tell you here. And that is why can hemodialysis allow ambulation? Can you walk around with hemodialysis? No, but you can walk around with peritoneal dialysis. Is it clear? So these are the points with which we differentiate HD and PD. So basically HD involves a too large hemodynamic shift, whereas PD compared to HD requires a smaller hemodynamic shift. HD is a fast process, that is why it is done intermittently. We do it twice or thrice a week, whereas peritoneal dialysis is slow and it is a continuous process, it never stops. Number 3, HD cannot be done at home. It usually requires a health facility or a hospital facility. Complications are more in HD, less in HD compared to PD. You cannot hemodialyze a hemodynamically unstable patient. You require that is a PD. Clear? And last but not the least, a patient cannot be walking around while he is being hemodialyzed, because it is a too much of a hemodynamic shift. He needs to sit or he needs to lie down. But a patient, yes, G1 means colloquially it is stage 1, yeah. But a patient of peritoneal dialysis can walk around also. Is it clear? This is the difference. Now, let me just explain you the basic difference in principle between the two. Now, you will not be asked this. But I thought, let me tell you, for many people have this interest, sir, what is hemodialysis? How is it done? Because most of you have not entered a hemodialysis ward or room ever. So I thought, many of you might have relatives or neighbors who are on hemodialysis, so you have that inquisitiveness, and I always welcome inquisitiveness. So first of all, let me tell you, this is how a modern hemodialysis machine looks like. We think what not it will be. No, this is a standard hemodialysis machine which has, and this is the dialyzer. This tube, this small tube, this is the dialyzer. Is it clear? This is the dialyzer. Ambulation means walk around. Now, basically what happens is, the principle of hemodialysis is this. Just see here, just see what is happening here. A person is sitting here. So, there are three portions. There are three main parts of a hemodialysis process. Number 1 is the arteriovenous axis. Number 2 is the dialyzer. And number 3 is the dialysate. So these are the three main parts of a hemodialysis apparatus. What do you mean by that? Number 1 is the AV axis. So basically from here, can you see, from here the blood is exiting out, it is going out, it is passing through a blood pump, and ultimately it is entering into a dialyzer, a dialyzer is nothing but a lot of semi-permeable membranes which are attached in parallel. So these are a lot of semi-permeable membranes. Now in the dialyzer there are semi-permeable membranes inside which blood flows, and outside the dialyzer you have you basically have the dialysate, which is composed of the saline, the water, and these two dialysate solutions ultimately that go inside, and ultimately there is a exchange of toxins and water across the dialyzer membrane from the blood into the dialysate and from the dialysate into the blood, and ultimately this is the purified blood, this is the purified red blood which enters back into the body, and this is the unpurified or the toxin blood which was there, which went inside the machine. Is it clear? Is it absolutely clear? So for those of you who want to draw a schematic diagram, let me just give you a schematic diagram. So basically if this is the dialyzer, and inside this there is a blood which is flowing. Yeah, please bear with me for a minute. I know my drawing skills are not that good, so just pardon me if you do not like my drawing. So this blood basically enters the dialysis apparatus, flows through the dialyzer, and the purified blood returns back. Through the dialyzer, on the outside you have the dialysate. So this yellow colored is outside is the dialysate, and this tubing, this inside semi-permeable membranes is basically the dialyzer, and this, as I earlier told you, is the AV axis. So these are the three parts, and please see what happens eventually. So basically this is the blood that enters the dialysis machine, enters the dialyzer, inside flows here, and outside you have the dialysate, and across this semi-permeable membrane which has a dialyzer, there are the exchange of toxins and the diffusion of toxins and the exchange of water that takes place, and ultimately the pure blood returns back from the dialyzer into the body after getting cleared. Is it clear? Is it absolutely clear? So this is the process of hemodialysis. Now the beauty is the dialysate composition you can change according to your own needs. So basically, if you are dialyzing a hyponatremic patient, so what do you want? You want that there should not be any diffusion of sodium from the blood into the dialysate, because if you lose more sodium, you can be further hyponatremic. Instead, some sodium must leak from the dialysate into the blood. So what will you do? The exchange is across a concentration gradient. So what will you do? You would slightly raise the sodium in the dialysate fluid, so that some sodium gets corrected into the blood and you ultimately gain sodium and not lose sodium. Supposingly if you are dialyzing an extremely hyperkalemic patient, a potassium is 7.5. So what will it do? What will it be? What will you do? You will what will you do? You will do a potassium free dialysis. So we say potassium free because we remove all the potassium from the dialysate, and so that the concentration gradient between the blood and the dialysate becomes very high for potassium, and all the potassium comes from the blood into the dialysate, and from 7.5 you immediately get less. Is it clear? Absolutely clear. I hope you have understood the principle of dialysis. This is the principle of dialysis. I mean the hemodialysis. Okay? And we usually, because it is an intermittent process, that is why this is known as intermittent hemodialysis, and we do 4 hourly sessions. 4 hourly sessions 2 to 3 times per week. The international guidelines recommend that a minimum of 12 hours of dialysis is required in a week. 12 hours of dialysis required in a week to simulate the normal renal function. But due to due to financial challenges, and in Indians, many patients tolerate twice weekly dialysis for many years. And ultimately, when they lose all the residual renal function, they have to be shifted to thrice renal dialysis, thrice weekly dialysis. So we basically give 4 hourly sessions, which are twice to thrice in a week. Is it clear? Is it clear? Very good. But you will not be asked this. You will be asked complications of dialysis. So let me straight away jump to complications of dialysis. And let us start the acute complications of dialysis. In the acute complications of dialysis, the first and foremost that we shall be discussing is very, very important. That is hypotension. That is hypotension. हेलो हाँ, ये ब्लैकआउट हो गया था, अब आ गया ठीक. Yeah, so I just called the technical team and automatically came back. So the acute complications of dialysis we were discussing, and we will start with the very first. The first complication of dialysis is hypotension. And let me tell you, this is the most common complication of hemodialysis. Sir, what do you mean by hypotension during dialysis? Hypotension during dialysis is known as, or is defined as, a systolic blood pressure fall of more than equal to 20 millimeter mercury, or a mean blood pressure fall, mean arterial pressure fall of more than equal to 10 millimeter mercury, which requires interventions. Which require intervention. So I told you, hemodialysis, it involves what? You basically take out a lot of blood. You basically take out blood out of the body, and the blood is running in the extracorporeal circuit, yes or no? So the hemodynamic shift is quite a bit. So immediately when you take out the blood and you send to the extracorporeal circuit, it might so happen that the patient becomes hypotensive. So what is known as intradialytic hypotension is defined as a systolic blood pressure fall of more than equal to 20 mmHg, or a mean arterial pressure fall of more than equal 10 mm Hg associated with nursing interventions. Now tell me, if you were posted in a dialysis duty and you saw the monitor beeping, ping, pim, beep, 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 and it read BP 86/60, what is the first thing, reflex action that you will do? First reflex action that you will do is number 1, stop dialysis. The first thing that you will do is stop dialysis. Number 2, what you can do is you will start fluids because the BP has dropped due to rapid or excess of ultrafiltration. So you will give an IV fluid bolus. You can also start the patient on inotropes. So this is the most common complication of dialysis, which is often asked. Clear? You have to stop dialysis, you have to give IV fluids, and you have to start inotropes. And what is the most common cause of intradialytic hypotension? The most important cause of intradialytic hypotension is excess fluid removal or excess ultrafiltration. So basically, we use a term known as ultrafiltrate in dialysis. When we prescribe dialysis, we write hemodialysis for 4 hours. Ultrafiltrate will be 2 liters or 3 liters or 3.5 liters. That is basically based on the weight gain. So basically, before a patient enters dialysis, we take a pre-dialysis weight, and after he leaves, we take a post-dialysis weight. So basically, with regard to the total body water composition, we fix a dry weight for the patient. We say that the optimal dry weight of this patient is 63 kgs. So next day, when he comes for dialysis and he weighs 65 kg, it means he has gained 2 kgs in the last 2 days. So we set an ultrafiltrate of 2 liters today. So that 2 liters means 2 kgs, and you remove 2 liters fluid from the patient. But what happens if he comes with, say, a weight gain of 4 to 5 liters? If he gains 4 to 5 kgs, so we will want to remove more water. So we set an ultrafiltrate of 4 liters, 4.5 liters. And then if we remove extra fluid or excess ultrafiltrate or a fluid from the body, the patient develops hypotension. Clear? After hypotension, what else can you have? You can have number 2, muscle cramps. Sir, why do muscle cramps develop? Muscle cramps develop again due to number 1, rapid volume removal, and number 2, hypoosmolarity. Sir, how do you treat it? You increase plasma osmolarity, or you can give carnitine, which is an antioxidant. So basically, muscle cramps develop why? You develop if your patient develops hypovolemia or dyselectrolytemia, or there is hypoosmolarity, there can be hypoosmolytes in the blood. So it will lead to muscle cramps, and you have to increase the plasma osmolarity. You can give dextrose and stuff like that, or you can give carnitine, which is basically an antioxidant. After muscle cramps, what can the person have? The person can also have a very, very peculiar side effect known as dialysis disequilibrium syndrome. Dialysis disequilibrium syndrome, let me tell you why does it develop. Number 1, first of all, it's a rare entity and it develops during the first dialysis. So if a patient has not developed DDS in the first session of dialysis, he will never ever develop in his rest of the life. Now please try to understand, why does DDS occur? Say a new patient has come to you, a new CKD patient has come to you, and you are dialyzing him for the very first time. When you dialyze him for 4 hours, suddenly the urea content in his blood drops from say 200 to 100. There is sudden drop of urea in the body, and now the homeostatic milieu of his body was accustomed to that high urea, and when you remove the urea, there will be a reverse osmotic shift, and that is why DDS will occur. So basically the cause is due to why does urea occur, because that is known as reverse osmotic shift. That is known as reverse osmotic shift. I hope I am absolutely clear to all of you. I hope you are absolutely understanding clearly. Okay? Okay? So that is reverse osmotic shift. So to prevent this, for prevention, we give shorter sessions initially. So I told you the standard HD sessions are of 4 hours, but initially we dialyze a patient with 2.5 to 3 hours for the initial 2 to 3 sessions, and then we start him on 4 hours. Is it clear? Absolutely clear? That is why it does not develop usually only if a person is not taken care of and he is dialyzed so much, he develops DDS. Next, after dialysis equilibrium syndrome, what can the patient develop? The patient can develop what is known as anaphylactoid reaction. Anaphylactoid reaction. Sir, why does this develop? This develops as a reaction due to the bioincompatible cellulose membrane, or it can occur due to the dialyzer sterilant, which is ethylene oxide. So initially earlier we used to use bioincompatible cellulose dialyzer membranes. The dialyzer membranes used to be made up of cellulose, which were bioincompatible, and that would incite an immune reaction. Also, the dialyzer, the manufacturer used to sterilize the dialyzer with ethylene oxide, which also would incite an immune reaction, and that could lead to anaphylactoid reaction. But presently we do not use cellulose membranes also. We use biocompatible membranes, and we have avoided sterilizing with ETO. We sterilize it with gamma radiation. So basically both of them do not occur right now. I hope I am absolutely clear to all of you. And one of a very rare complication that can occur is acute blindness. So this is basically more of a quizzing and more of a MCQ type of a question, which you will not very commonly find. But say a person is undergoing dialysis or immediately post dialysis, the person tells you, "Sir, I cannot see anything. Sir, I cannot see anything." What do you think will be the answer? What do you think will be the cause? It is ethylene oxide. Beta, ethylene oxide is a sterilizing agent. Acute blindness after dialysis can develop due to something which is known as posterior ischemic optic retinopathy known as PION. So for your sake, let me give you two MCQs. In rheumatology, you might have heard the name of a disease which is known as giant cell arteritis. Have you heard giant cell arteritis? So you know, in giant cell arteritis, there can be sudden onset plain blindness that is due to anterior ischemic optic neuropathy, whereas in after hemodialysis, you develop posterior ischemic optic neuropathy. So you know, there are two things you know already. One is EON, one is PION. EON after giant cell arteritis and PION after hemodialysis. I hope I am absolutely clear to all of you. I hope I have made myself absolutely clear to all of you. And this is basically not a very common complication that you will encounter. This is more of an MCQ or a theoretical entity, but that can definitely be asked. Is it clear? So acute blindness, if a person develops after hemodialysis, you have to say, sir, it could be posterior ischemic optic neuropathy. And you are reminded of anterior ischemic optic neuropathy, which you had studied in giant cell arteritis. Now, if I ask you a very, very basic question, which you had studied in giant cell arteritis, can you tell me anterior ischemic optic neuropathy develops due to involvement of which artery? Can you tell me anterior ischemic optic neuropathy develops due to involvement of which artery? Sir, you have come to teach me nephro. Please do not enter into ophtha and rheumato. Many people are telling me that. Yes? Let me see the comments. What are you all saying? So, yes, sir. Anterior ischemic optic neuropathy develops due to the involvement of the posterior ciliary branch of the ophthalmic artery. It develops due to the involvement of posterior ciliary branch of the. This has also been asked. Posterior ciliary branch of the ophthalmic artery. An ophthalmic artery. So this has also been asked as an MCQ. Good. So with this we complete the acute complications of hemodialysis. Now coming to the chronic complications of hemodialysis. The chronic complications of hemodialysis are number 1, anemia. Number 2, amyloidosis. And that amyloidosis is due to deposition of beta 2 microglobulin. Beta 2 microglobulin. Next, very, very important. Adynamic bone disease. And last but not the least, it can also cause dementia. So, chronic complications of hemodialysis are anemia, amyloidosis, adynamic bone disease, or dementia. Treatment for acute blindness, I do not know, that is in ophtha. I will refer him to an ophthalmologist. Clear? So that is not my concern here. You will be studying in your ophtha classes. Please do not ask me the treatment of anterior ischemic optic neuropathy and posterior ischemic optic neuropathy. Clear? So this is about anemia, amyloidosis, adynamic bone disease and dementia. This is about the complications of hemodialysis. After hemodialysis, come to peritoneal dialysis. And let me tell you the principle of peritoneal dialysis. Now just see one thing. You know, in hemodialysis, your blood was going out of your body. It was getting filtered through a dialyzer and then it was re-entering your body. But in peritoneal dialysis, what we have done is, we have tried to utilize the body's own reserve only. And what we have done is, we have now converted the peritoneal membrane into the dialyzer itself. So see, what do we do? What do we do? We have inserted a peritoneal catheter. We have inserted a peritoneal catheter into the peritoneum of the patient. This is the peritoneal catheter. And this peritoneal catheter we connect to a PD fluid. This is a peritoneal dialysate fluid, which is basically dextrose based. So we take a peritoneal dialysis fluid which is dextrose based, and we transfer it, we transfuse this peritoneal fluid into the peritoneal cavity via a peritoneal dialysis catheter, and then we leave it for 4 to 6 hours, and that is known as a dwell time. So what do we do? I am repeating it again. We have put in a peritoneal dialysis catheter inside the peritoneum of the body, and we transfuse through a set a peritoneal dialysate fluid into the peritoneal cavity, and we tell the patient, now you are free, do whatever you want to do, man. And now we leave it for a dwell time, that is 4 to 6 hours. And what happens during that time? What happens during that time is, you know that your parietal peritoneum is richly innervated, and it is a very, very vascular organ. It is a very, very vascular organ. So now what happens is, your parietal peritoneum acts as a permeable membrane, and this is if this is the barrier, this is your peritoneum. Your parietal peritoneum acts as your selectively permeable membrane. It has a lot of blood vessels. So on one hand it has blood, and on the other hand you have inserted PD fluid inside the peritoneum. So what happens? All the uremic toxins, they exchange from the blood into the PD fluid. All the extra water, it goes into the PD fluid along the osmotic gradient. And what happens is, after the dwell time, what do you do? Through the second port of the dialysate catheter, you take out all the PD fluid that you had given in. Now normally what is expected is, if you infuse 1 to 1.5 liters inside, when you take out, you wish to take out, if you inserted 1500 ml, you wish to take out 1700 or 1800 ml. Yes or no? Because if you do that, so you have removed the extra fluid also from the body. I hope I am absolutely clear. So this is the principle of peritoneal dialysis. I hope I am clear. This is the principle of peritoneal dialysis, where you have a peritoneal dialysis catheter. There is a peritoneal dialysis fluid which is transfused into the peritoneal fluid. The patient is free. That is why I say a patient can be ambulatory. After the dwell, he can walk around if he wishes to. Absolutely, he can walk around if he wishes to. And then after the dwell time, when the exchange has taken place, when the osmotic gradients have settled, when the diffusion gradients have settled, you take out the fluid which was there in the peritoneal fluid and peritoneal cavity, and now that fluid is no longer the previous fluid. It has also the toxins and extra water. So you would ask me, sir, why is the fluid dextrose based? Because see, you had to infuse a hyperosmolar fluid inside. Because why, sir? If the fluid is not hypertonic or hyperosmolar, it will not draw the extra water. It will not draw the extra water. So it is dextrose based, so that it is hypertonic and it pulls in the water, because water flows from a hypotonic state to a hypertonic state. Is it clear? The name is known as dwell time. You will never be asked all this. Why am I telling you all this? Because when I teach you something which is absolutely grey to you, I don't like that. I want to give you some concepts and then teach you, so that you at least develop certain understanding. Is it clear? That is dwell time. Clear? So now come to complications of peritoneal dialysis. Complications of peritoneal dialysis. The complications of peritoneal dialysis are clear. The complications of peritoneal dialysis are, number one, very very important, very important. The complications are, so what do you think, sir? Or if you will insert a peritoneal dialysis catheter inside the body, what do you think? That, Khilji staph aureus and Aurangzeb Escherichia coli and all those bacteria, will they leave you like that? Will they not do anything to you? Of course, sir, they will do something to you. They will not leave your peritoneal cavity like that. And the very important complication of peritoneal dialysis is infection or peritonitis. So, a very important complication is peritonitis. Clear? And the treatment is intraperitoneal antibiotics. So we infuse intraperitoneal antibiotics with that same dialysate catheter which we had inserted in the peritoneum. We give intraperitoneal antibiotics. Clear? After that, you have inserted you insert daily a lot of dextrose inside the body. So that dextrose, definitely some of it will diffuse into the blood daily, and ultimately a very important metabolic complication is hyperglycemia. And it also causes hyperlipidemia. It also causes hyperlipidemia. Is it clear? So it causes hyperglycemia and hyperlipidemia. It causes hyperglycemia and hyperlipidemia. Next, very important. Next is very important. That is hypoproteinemia. So as I taught you, as I was teaching you that schematic diagram. So due to this transfer, what happens when a patient is on long-standing peritoneal dialysis, the vascular permeability of these peritoneal capillaries increase, and what happens is there is also leakage of certain proteins from year to year. So due to increased vascular permeability, you tend to lose protein also. And ultimately what you develop is known as that is hypoproteinemia due to increased vascular permeability. Is it clear? And last but not the least, what do you think? You will keep 1.5 to 2 liters in the peritoneal fluid in the peritoneal cavity daily, and will the abdominal muscles will not become loose and lax? Of course yes. That is why ultimately it will weaken the muscles, peritoneal muscles, and it will lead to hernia. So these are the complications of peritoneal dialysis. I hope I am absolutely clear. This is enough. You will not be asked anything more or beyond this from the dialysis section. Is it clear? I have taught you more than what was required from dialysis, so that your concepts and your idea, because all of you are becoming MBBS. So MBBS, when you say Bachelor of Medicine and Bachelor of Surgery, you must at least have some amount of holistic idea or approach towards everything which is important, and dialysis of course, which is very important. Clear? Good. So with this we have completed the Now, one thing which is very, very important, nutrition in CKD. On this topic itself, there was a question asked in AIMS November 2019. In AIMS November 2019, this question came, and it is very, very important that, sir, what nutrition will you prescribe to patients of CKD? Now, let me straight away jump to the question first, and after the question, I will tell you what I was trying to tell you. Okay. So the question in AIMS November 2019 was, what is the best nutritional regimen to end stage CKD patients? What is the best nutritional regimen to end stage CKD patients? Is it low calorie, low volume, low calorie, high volume, high calorie, low volume, or high calorie, high volume? Now, the KDIGO guideline for patients of CKD who are not on dialysis and patients who are on dialysis are as follows. Basically, for patients who are not on dialysis, we prescribe a low protein diet, because the higher protein you give, the more creatinine they will have and the more uremic symptoms they will have. So you will prescribe a protein of 0.8 milligram per kg per day, while those who are on dialysis, we prescribe them of 1.2 to 1.3 mg per kg per day. This is about protein. Coming to fluids, in CKD patients who are not on dialysis, we prescribe them a fluid limited intake, and that basically depends on the urine output. Whereas a person who is on dialysis usually has very low urine output, to him also we prescribe a very low fluid intake. Coming to calories, I told you most of the CKD patients, they suffer from malnutrition, protein energy malnutrition, and that is why you have to prescribe a high calorie intake to all the patients of CKD, which is usually approximately more than 35 kilocalorie per kg per day. I hope I am absolutely clear to all of you. And coming to the sodium intake, it will be less than 2 grams per day for both the patients. Now, if I have to sum it up, let me do it for you. So, coming to nutrition in CKD, it depends whether the person is on dialysis or not on dialysis. On dialysis, not on dialysis. Okay. Now, if a person is on dialysis, let's come to calories first. Now, if a person is or is not on dialysis, in both cases, you have to give him a very high amount of calories, which is approximately 35 kilocalorie per kg per day. This will also be 35 kilocalorie per kg per day. So it will be a high calorie intake. Coming to protein, because a person is not on dialysis, so we have to prescribe him approximately 0.8 grams per kg per day. It has to be a low protein diet. Whereas a person who is, I'm so sorry, this is on dialysis, right? So we have to prescribe him approximately 1.2 grams per kg per day of protein if a person is on dialysis, while if he is not on dialysis, we prescribe him 0.8 gram per kg per day. Slightly lower protein, because if you give him more protein, protein is a source of nitrogen content in the body, and it will ultimately lead to high blood urea nitrogen, and that will lead to problems. Coming to water. Now, water actually depends on urine output. It actually depends on urine output, because there cannot be a flat answer. There cannot be a flat answer to urine out of water intake. There are CKD patients who are non-oliguric, who produce good 1 liter, 1.5 liter till advanced stages. usually of the tubulointerstitial variety. So to them, you might not prescribe fluid restriction, but basically those mostly who are on dialysis, and even those who are not on dialysis, most of the CKD patients are oliguric. So usually in a general note, you prescribe them fluid restriction. Which basically depends on the urine output. So the amount of fluid intake that you will prescribe is basically dependent on the fluid intake. Is it clear? Absolutely clear. And last but not the least, which is very important, that is sodium intake. Which will prescribe less than 2 grams per day, also less than 2 grams per day, Is it okay? So this is the gist that I want to give you. So our question was, a person who is end-stage renal disease, what will you give? You will give a high calorie and a low fluid intake. That was the question, because that only did not ask the absolute value. You basically ask the rough thing. Yes, it is normal to pass no urine till 1 day after dialysis, because usually most patients who are in dialysis for a long time, they don't produce urine only. They produce 30, 40, 50 ml of urine. Clear? So this is about nutrition in CKD. With this, we have completed CKD in very, very much details. I don't think so any facet of CKD is left for you to study. Everything is completed in absolute details. Is it clear to all of you? Now, today, we will start a new portion, a very, very important, which, I don't get enough time to discuss in most of the classes, but in your class, I have particularly taken out time to discuss it in brief, and that is renovascular hypertension. Renovascular hypertension is a cause of secondary hypertension. It is a cause of secondary hypertension, and you already know that the most common cause of secondary hypertension is what? Most common cause of secondary hypertension is renal parenchymal disease. And renovascular disease is not the most common cause, but it is one of the causes of secondary hypertension. So I hope this is absolutely clear to all of you. Clear? Absolutely clear? Now, so coming to renovascular hypertension, what are the clues? What are the clues for renovascular hypertension? Or when to suspect renovascular hypertension? Okay. Now, when do you suspect renovascular hypertension? The clues, that is when to suspect renovascular hypertension, are number one, onset of hypertension. When you have an onset of hypertension, which is a systolic blood pressure of more than equal to 160 mmHg, or a diastolic blood pressure of more than equal to 100 mmHg. So you have an onset of hypertension more than equal to 160 by 100 after 55 years of age. So straight away a person who is more than 55 years of age comes to you with symptoms, and you measure the blood pressure, and he straight away has a hypertension which is more than 160 mmHg in systolic, and more than 160 mmHg in diastolic blood pressure, for a person who is more than 55 years of age, you will definitely suspect this. The next thing, when will you suspect a renovascular hypertension is when there is a resistant hypertension. So when there is a resistant hypertension, and you must have been taught resistant hypertension definition in cardiology, that is, resistant hypertension is uncontrolled BP despite more than equal to 3 drugs, including a diuretic. So say a person who is a hypertensive patient and you have prescribed him, say, a calcium channel blocker and ACE inhibitor, and you have given him a diuretic also, say a thiazide diuretic, still his BP is 150 by 90 or 160 by 100. So he already has 3 drugs or more, still his BP is uncontrolled. That is the definition of resistant hypertension. And one of the causes of resistant hypertension is renal vascular hypertension. That is renal artery stenosis. You definitely have to be suspicious of resistant hypertension when you get it ever. The third important clue of renovascular hypertension, whenever you get it, is when you get malignant or accelerated hypertension. So when you get malignant or accelerated hypertension that is associated with end organ damage, that could be in the form of papilledema, that could be in the form of left ventricular failure, that could be in the form of left ventricular hypertrophy. So if you get end organ damage along with a very high blood pressure in a patient, always be suspicious of a secondary hypertension and always exclude renovascular hypertension. Is it clear to all of you? Clear? Absolutely clear? Next. The next thing is, when the age of onset of hypertension is less than 30 years. So you have understood that essential hypertension or primary hypertension usually develops in the age group 30 to 55. That is the age, the middle age. So if a person is too young or if he is too old, if a person who develops hypertension is too young or too old, you always be careful and you always have to be suspicious of secondary hypertension, and of course you cannot exclude renovascular hypertension. Clear? Next, the fifth clue of renovascular hypertension is when there is unexplained decline in kidney function that is, when creatinine rise is more than equal to 50% within 1 week of ACE inhibitor ARB, within one week of the commencement of ACE inhibitor ARB. So if you remember the story, ting tong, your nagging neighbor auntie had entered your flat and you had prescribed her ACE inhibitor or ARB, that is telmisartan you had prescribed, and the next day she told you that my creatinine has risen from 1 to 1.2 and you were petrified. You probably, you were rich and so you prescribed her a kidney transplant. But no, you knew that ACE inhibitor ARB normally causes rise of serum creatinine, but that is never beyond a physiological value. But if it increases more than 50%, and that that more than 50% rise within 1 week of serum creatinine is a definition, is a KDIGO definition of acute kidney injury. So never ever will you develop acute kidney injury normally with a patient with ACE inhibitor ARB, and if you develop, that probably he already has a compromised renovascular status. That is why the person has developed this. Is it clear? Next, I told you that if a patient has high BP with unequal kidneys, that is, the difference in size is more than 1.5 centimeter, always suspect renovascular hypertension. I told you, always suspect renovascular hypertension. The creatinine rise is less than 25%. The acceptable creatinine rise is less than 25%. If it increases by more, you always have to be very, very suspicious. Is it clear? So it should be less than 25%, that is normal. If it is between 25 to 50%, you usually reduce the dose. If it is more than 50%, you stopped it. This is a dictum, practical dictum that we follow. Clear? Next. What is the next cause that you will, the next clue that you will think of renovascular hypertension? Now, if the patient has hypertension with unequal kidneys, you will also be suspicious of renovascular hypertension. If the patient has recurrent acute pulmonary edema, okay, because a very typical presentation of renal artery stenosis is flash pulmonary edema, which develops recurrently, or a patient has refractory heart failure, recurrent heart failure with abnormal kidney function. So if these clues are there, in your patient, always be suspicious of renovascular hypertension. I am repeating what I just said. If the patient has an onset of hypertension beyond 55 years of age, so two causes you have understood, if it is more than 55 or if it is less than 30. If a patient has resistant hypertension, that is very high BP beyond 3 drugs, malignant hypertension, that is with end organ damage. So 2 age criteria, 2 BP criteria. Next, if there is a decline in kidney function with ACE inhibitors, very, very specific. If there is unequal kidneys and if there is recurrent acute pulmonary edema. So there are 7 clues. 2 are dependent on age, 2 are dependent on the type of blood pressure, 1 is due to size of kidney, 1 is due to increase in the creatinine with ACE inhibitor nagging neighbor anti, and 1 is due to flash pulmonary edema. So they are 7, they are recurrent heart failure or flash pulmonary edema. Yes. So there are 7 clues. I repeat, 2 are due to age, 2 are due to definite threatening hypertension, 1 is due to kidney size, 1 is due to nagging neighbor anti, and the last is due to refractory pulmonary edema. There are 7 clues. Okay? This is known as flash pulmonary edema. Flash when it develops in a flash. So this is about causes. What are the clues to renovascular hypertension? Now, if I ask you, what is the most common cause of renovascular hypertension in age? So, if I ask you, most common cause of renovascular hypertension in more than 50 years of age, and in children and young adults. So basically, if I told you that this patient is a patient of renovascular hypertension and I told you his age is 60 years old, you will immediately tell me that this is a patient of atherosclerotic renal artery stenosis. So the cause will be atherosclerosis. But if I tell you, sir, this is a patient of renovascular hypertension and he is a 20-year-old female, you will tell me, sir, that is fibromuscular dysplasia. In young people, the most common cause of renovascular hypertension is fibromuscular dysplasia, which is abbreviated as FMD, which I know you have very little clue about. Atherosclerosis is the same atherosclerosis that develops in the systemic peripheral arteries causing hypertension, develops in the coronary arteries causing coronary artery disease. But FMD, I know very many of you have heard the names only of, and you do not know much about. So I will give you a briefing about FMD. So FMD, what is FMD? It is a non-inflammatory. Many people of you might be thinking, sir, it is a type of vasculitis. But no, it is a non-inflammatory condition, so it is not vasculitis. It is a non-atherosclerotic. It is a non-inflammatory, non-atherosclerotic. So there is neither atherosclerotic disease, non-inflammatory disease. So it is not a vasculitis. Otherwise, Srinath sir might have taught you. Definitely. So what is it? What is it, sir? It is a vasculopathy. It is a vasculopathy. So it is a disease of the blood vessel. It is a disease of the blood vessel. Sir, what involved in the blood vessel? Sir, what is the problem in the blood vessel? It is characterized by smooth muscle cell proliferation and fibrosis. So it's a disorder of the smooth muscle cell and the fibrosis, which is basically the tunica media of the blood vessel. It is the disorder of the tunica media of the blood vessel. I hope I am absolutely clear. So it is a disorder, it is a defect of vascular collagen. It is a defect of vascular collagen. So you can understand, inside the tunica media of the blood vessel, the collagen is defective. So the smooth muscle cell is proliferated and it gets fibrosed. Ultimately the vessel contracts from inside due to fibrosis, and the patient develops renal artery stenosis. I hope I am absolutely clear. Now, what are the risk factors? So, a female patient came to my clinic, and I saw her. There are some signs which you can understand the person is a smoker. I hope you can understand the person who are smokers. You can know from the color of the lips, from the nicotine tar that is present on the fingers, from the color of the teeth. And I understood that she was a smoker, and I asked her very humbly that, ma'am, do you smoke? She said, yes, sir. I said, ma'am, you are a female, you are a smoker. Ma'am, already there's a very, very petrifying disease with a female to male ratio of 9:1. So ma'am, you are very, very prone to systemic lupus erythematosus, which, ma'am, all of us think SLE is equal to malarash. That's a separate story. So, ma'am, you are very prone to SLE. She told me in her defense, she was a learned person. She told me, sir, but I will be protected from ulcerative colitis. I have told you this. But then, now I had a very, very good armament with myself. I told her, ma'am, so what if you will protect your gut from ulcerative colitis? But ma'am, not only will you have SLE, you will also have a disease which is known as fibromuscular dysplasia, because these two are a very, very important risk factor for FMD. So, ma'am, if you are a female smoker, God protect you from two diseases. One is lupus and one is FMD. So, ek taraf kuan, ek taraf khai, and both are ready to pounce upon your kidneys, ma'am. So, God save you. Come to clinical features. Now, FMD involves the renal vessel. FMD basically involves the renal artery and the cerebral arteries. So that is why if the renal artery is involved, you know what will you get? You will get high blood pressure, you will get high creatinine. And if you involve the cerebral artery, you can get headache. You can also get stroke. So you can get headache and you can also get stroke. I hope I am absolutely clear. So the two vascular beds that are involved are renal artery and cerebral artery. Clear? Sir, if I investigate, before investigation, sir, I want to be a clinician, so I will make use of the necklace which is dangling around my neck, and sir, I will make use of it, so I will hear a renal bruit. I will hear a renal bruit, which is heard in the para-umbilical area. In the para-umbilical area, just adjacent to the umbilicus. It is heard just adjacent to the umbilicus. I hope I am clear. It is heard in the para-umbilical area. Clear? No break, sorry. No break. And last but not the least, how will you investigate? In investigation, if you do an angiography, what will you get, sir? You will get a very, very specific and a very, very classic appearance, which is known as string of beads appearance. You will get a string of beads appearance. You will get a string of beads appearance. Clear? And last but not the least, somebody is saying bruit. Sir, what is bruit? And what is a murmur, sir? What is a bruit and what is a murmur? All the intelligent clinicians in the house, please tell me, what is the difference between a bruit and a murmur? Sir, when you hear it over the precordium, that is a murmur. When you hear it outside the precordium, that is a bruit. When you hear it over the heart, that's a murmur. When you hear it over a blood vessel, that's a bruit. I hope I'm absolutely clear to all of you. I hope I'm absolutely clear to all of you. Clear? And last but not the least, how will you treat this patient? How will you treat this patient? The treatment will be, sir, the treatment will be for FMD and for, say, atherosclerotic renal artery stenosis. What is the difference in treatment, sir? The difference in treatment is, sir, for atherosclerotic renal artery disease, the treatment of choice is medical management. The treatment of choice in atherosclerotic renal artery disease is medical management. Sir, what do you mean by medical management? Sir, you basically give RAS inhibitors plus statins. You give RAS inhibitors plus statins in atherosclerotic renal artery disease. That is, in the atherosclerotic renal artery disease, you basically give medical management is a treatment of choice. But in fibromuscular dysplasia, because it is not an intraluminal defect, it's an intra-wall of the vessel defect. So any medical management will not work because it's a non-atherosclerotic disease. It's a non-inflammatory disease. I hope I am clear. I hope I am clear. So it will not work. So what will you do in fibromuscular dysplasia? In fibromuscular dysplasia, the basic treatment is angioplasty. The basic treatment is percutaneous renal artery angioplasty, and usually that angioplasty is without stenting. Whereas for atherosclerotic renal artery disease, what you do, sir, if the medical management fails, then you will do angioplasty with stenting. Sir, why do we have to deploy a stent, sir? Sir, a stent is for that. A stent is for basically an intraluminal defect. ACE inhibitor given in renal artery stenosis, of course in unilateral. J. In bilateral, of course, we will not give because it's an absolute contraindication. I hope you know that. So it is RAS inhibitor is given only in unilateral renal artery stenosis, not in bilateral. So the basic crux is in FMD, you do an angioplasty without a stent because a stent is basically deployed for an intraluminal defect. But in atherosclerosis, you have an intraluminal atherosclerotic plaque. So a stent can able to, widen the vascular lumen and it will help in atherosclerosis. But in FMD, it is not an intraluminal defect. So you just need to do an angioplasty to disrupt the collagen and the luminal lumen will be wider. So this is the answer or the treatment of renal artery stenosis, which is atherosclerotic and which is fibromuscular dysplasia. So Vishnu Sasikumar says when a physician fails, surgeon comes, and basically let me tell you, when a surgeon is stuck anywhere, he calls a physician. Okay. So this is how you treat renovascular hypertension, and this is how you treat all of it. So this is about renovascular hypertension and renal artery stenosis. So we have discussed all of it in great details, in absolute details. Do not worry, we are coming back. Do not worry, the tech team is here. Yeah. So one thing I just forgot to mention it for you. That was when I was teaching you renovascular hypertension, when to suspect, and it is a common cause of, it is a cause of secondary hypertension. Well, the most common cause of this. Just write down two more points here. How to investigate of renovascular hypertension. The investigation of choice or the screening test is USG Doppler. So with ultrasound Doppler, that is the investigation of choice or that is a screening test. But the gold standard test, or which is the best test, is angiography. So this is how you investigate renovascular hypertension. I hope I am clear. Clear? Now, one thing which I have received a few doubts also about, there is also a test which is also mentioned in Harrison, that is basically known as a captopril enhanced renogram. This is also used. This is again basically a radioisotope scan used to investigate renal artery stenosis, but I will just tell you 2 lines about it which are asked in MCQ. It is useful in unilateral renal artery disease, and it has a high negative predictive value. Why is it used? It has a very high negative predictive value for renovascular hypertension when it is normal. So basically what we do is we do a radioisotope scan, but we enhance it with captopril. So when you give a captopril, which is an ACE inhibitor, you know that it will further aggravate the stenosis of the vascular bed which is previously stenosed. Yes or no? Yes or no? It is obviously, it will enhance the stenosis of the already stenosed vascular bed. So now what will happen? Now if there is any vascular stenosis which was say mild to moderate, it will become severe and it will manifest in the renogram. So we will understand this, but of course we will never give this in bilateral renal artery disease. And if this is normal, we know that the patient does not have unilateral renal artery stenosis also. So it has a very high negative predictive value, and I know all of you are students of Dr. Shetty and Dr. Siddharth Mishra, so you are champions of the word predictive value which is negative or positive. I know that very, very well. You are champions of this word. Yes or no? You are champions. Clear? So with this we come to the end of renovascular disease also. We come to the end of renovascular disease. Also. Next, coming to cystic diseases. The next, which is a very, very short chapter. The cystic diseases of the kidney. Coming to cystic diseases of the kidney. No, it is not the end of the day. Don't you guys want to study cystic disease of the kidney? Those who want to study, please give me a thumbs up. Please give me a thumbs up. Those who want to study this topic. Those who want to study this topic, please give me a thumbs up. I am waiting for your thumbs up. Beta, today only I told you, if you want to achieve something that you have not achieved before, please, you have to do something which you have never done before. Clear? So please do not say that, you know, your head is paining or all that stuff. Because that will not help you in the long run. Because that will not help you in the long run. Because the competition is getting very stiff day after day. And you know, and I want to cover as many topics as possible for you all, so that ultimately you are the winner and you don't have anything which is left behind. Is it clear? So in cystic disease of kidney, the first topic is ADPKD versus ARPKD, which I will not teach you because I know this has already been covered in pathology. I have talked to Dr. Ranjit, he has completely taught you this topic, and I will not teach you any further because this will also be taught to you in a urology class. So I will not teach you this. What I will teach you is that topic which nobody will teach you, and I know That topic is again the interface between pathology, medicine, urology, and a lot of questions are asked these days. Sorry. That is MCKD versus nephronophthisis. Clear? Sir, what is MCKD? MCKD का full form है, let me tell you what is the full form of MCKD. It is medullary cystic kidney disease. But sir, this was the old terminology. MCKD is now known as autosomal dominant tubulointerstitial kidney disease. So the new name for MCKD is tubulointerstitial kidney disease. Yes, Dr. Chandu Reddy, it is important for NEET. In fact, MCKD has been asked 2 years back. MCKD has been asked. Tubulointerstitial kidney disease. And as always, I will try to give you a very high yielding table. I will try to give you a very high yielding table. Clear? So, MCKD, which was previously known as medullary cystic kidney disease, the terminology has been now changed to autosomal dominant interstitial kidney disease. And the abbreviation is ADTKD. ADTKD. So, what is the difference, or what is? Let us study in a comparison high yield table the difference between MCKD and nephronophthisis. Nephronophthisis. So, the inheritance. As the name has already told you, the inheritance of MCKD is autosomal dominant, whereas nephronophthisis is autosomal recessive. Most of you are thinking, sir, I have heard this name somewhere before. Can you tell me where have I taught you the name before? Where have I taught you nephronophthisis yesterday? Sir, you taught us when you were teaching us most common childhood onset genetic cause of CKD, and sir, you lured us and you pushed us into saying ARPKD, and then where you happily and very sadistically you proved us wrong and you told us that all the rest of the country has been answering this, but this is not the answer. Answer is nephronophthisis. Remember? Very good. So the inheritance of MCKD is AD, while this is AR. This is AR. Next, kidney cysts. Now, medullary cystic kidney disease may or may not have cysts, but nephronophthisis always has cysts. It always has cysts. Next, kidney size. Now, if I ask you what is the size of the kidney of autosomal dominant polycystic kidney disease, I already told you it is that disease of CKD, it is that exception CKD, which where those CKD the size is not reduced, and rightly so, because the kidney has a lot of cysts. So the size of the cyst causes the kidney to bulge and swell, and that is why the size of the kidney is more than normal. These two are also cystic kidney disease, yes or no? So you must be thinking that these also must be having large kidney sizes. They must be having, yes or no? Yes sir. But sir, let me tell you the exception. The kidney size here is not increased. In fact, it is normal or it is decreased. It is normal or it is decreased. So ADPKD was that CKD which had an increased size, and these two are those cystic kidney disease which have a reduced size. Which have a reduced size. Next, extra-renal clinical features are absent in medullary cystic kidney disease and they are present in nephronophthisis. So if I ask you a true or false, which is now an inclusion in the AIMS criteria, AIMS question bank, true or false, if I ask you, nephronophthisis is strictly a renal disease, true or false? Answer is false, because nephronophthisis has extrarenal features. Sir, in fact, medullary cystic kidney disease is strictly a renal disease because it does not have extrarenal features. So this is the basic difference between ADTKD and nephronophthisis. Now please develop the habit of calling it ADTKD rather than MCKD. I hope I am absolutely clear to all of you. Clear? I will tell you why. Don't worry. Now, I think it's raining outside or what? I'm hearing a lot of noise. Clear? So this was till here only. And now I will tell you a few more MCQs about nephronophthisis. So if you ask me, sir, extrarenal features आपने बोल दिए, what are the extrarenal features? Yes, it is decreased only. What are the extrarenal features, sir? The patient can have retinitis pigmentosa. The patient can have skeletal dysplasia. The patient can have cerebellar hypoplasia. The patient can have Bardet-Biedl syndrome. And sir, I am very fond of learning syndrome, sir. If a patient of nephronophthisis develops retinitis pigmentosa, that is known as senior Loken syndrome. If a patient of nephronophthisis develops cerebellar hypoplasia, that is known as Joubert syndrome. And these are old DNB questions. So the board is the same, it is the NBE. So it can ask you a simple one-liner. What is senior Loken syndrome? It is a combination of nephronophthisis with retinitis pigmentosa. So these are the extrarenal clinical features of nephronophthisis. And nephronophthisis, the gene is basically NPHP. The mutation of the gene NPHP leads to the protein which is known as nephrocystin. So basically NPHP is the gene which is the mutated gene, and NPHP, the gene, forms the protein which is nephrocystin, which is responsible for ciliary function. So very, very tactically, PGI Chandigarh asked you once, nephronophthisis is a ciliopathy. Tell me true or false. Tell me, nephronophthisis is a ciliopathy, true or false? I am continuing with the same thing. I am continuing with nephronophthisis only. It is a ciliopathy. Absolutely true, sir. Why, sir? Because ultimately, sir, it is the protein which is the nephrocystin which is getting hampered, which is responsible for ciliary function. So, sir, it's basically a disease of the cilia. Is it clear? Is it absolutely clear? And this has been asked previously in PGI Chandigarh. And what happens here is, so what is the pathogenesis? Somebody was asking, sir, why despite having cysts, does the size decrease or the size does not increase? Because, sir, the patient has chronic tubulointerstitial fibrosis. Because the patient has chronic tubulointerstitial fibrosis and so there are a lot of cysts in the cortex and medulla, and the patient develops a lot of fibrosis. That is why the name nephronophthisis. So ultimately the fibrosis leads to a shrunken kidney size. And where does the fibrosis primarily develop? It develops in the tubulointerstitium. And what is the distal part of the tubule, the collecting duct, responsible for? It is responsible for absorption of water. So ultimately what is hampered is there is impaired concentrating ability, and the patient develops polyuria. So you can recall a state where the person will lose a lot of water because the person is not being able to reabsorb water from the collecting ducts. And despite ADH being there, if a person is not able to reabsorb water from the kidneys, what is that condition known as? What is that condition known as? Quickly tell me, sir. That condition is a condition of, that condition is known as nephrogenic diabetes insipidus. So basically this nephronophthisis is a condition which is also a cause of nephrogenic diabetes insipidus, which is a congenital condition, and the patient will have polyuria, polydipsia, nocturnal enuresis and whatnot. I hope I am clear. So the patient will have polyuria, polydipsia, nocturnal enuresis, and whatnot. And sir, what is the treatment? The treatment is only one, sir. Sir, renal replacement therapy. So if you can afford, if you have a donor, if you have a blood group related donor, please go for a transplant. If you do not, please survive on dialysis. Is it clear? Absolutely clear. So in the early parts of in the early 2000s, AIIMS consecutively had asked this question, and the question was like this: a mother has come to a doctor with a 5 or 6 month old son, and she complains that there is a problem to thrive. The doctor measures the blood pressure is low. The mother says he frequently wets the bed, and he also has a problem in his eyes. So problem in his eyes, retinitis pigmentosa, bedwetting, polyuria, polydipsia, nephrogenic diabetes insipidus, and the combination of both will point you towards nephronophthisis, nocturnal enuresis. Nocturnal enuresis. Clear? Are you clear? Absolutely clear. So with this, we have also completed the medullary cystic kidney disease and your nephronophthisis. And last entity of today's topic, I will leave you early today. Do not worry. I will just teach you a very small topic, that is medullary sponge kidney disease, that too in very, very short. Sir, medullary sponge kidney disease is it is not as medullary cystic kidney disease. That was MCKD and this is MSKD. I will just tell you 3 or 4 MCQ points. Number 1, first of all, Senior Loken syndrome, retinitis pigmentosa के साथ I told you senior Loken syndrome. Senior Loken syndrome. Is it clear? Good. Somebody has already typed that. Now medullary sponge kidney disease is not equal to medullary cystic kidney disease. First of all, why? Because it is a sporadic benign disease. So what does it mean, sir? It is not a congenital disease. So medullary sponge kidney disease, it is not a benign, it is not a congenital disease, it is not a genetic disease, it is a sporadic benign disease. So it is not transmitted from one generation to the other like ADTKD or nephronophthisis. It is a sporadic disease. So sir, what is the problem? What is the issues? The issues are, number one, nephrocalcinosis. Number two, recurrent UTI. So it leads to calcium and phosphate stones. It leads to calcium oxalate and calcium phosphate stones. So basically, medullary sponge kidney disease does not present to you with, does not come into notice only. It's a benign disease. Sir, when does it come to notice? It comes to notice when a person has recurrent calcium stones. And then, if you investigate, you can diagnose a patient of medullary sponge kidney disease. And of course, it is not a hereditary disorder. This is not a congenital would be the wrong term. I am very sorry. It is not a hereditary disorder. By that I mean you have not inherited it from your parents. It is a sporadic entity. It is a sporadic entity which is a benign disease. So, sir, how is it diagnosed? Sir, it's an incidental diagnosis. Sir, why, sir? A person came to you with bar calcium stones. You got an imaging and you diagnosed medullary sponge kidney disease. Medullary sponge kidney disease. So, sir, what will you get, sir? How will you diagnose, sir? Sir, when you image it, in imaging, especially in an intravenous pyelogram, you will get a very classical, tomorrow I will show you the photograph, that is a brush-like appearance. A brush-like appearance, and of course, you will see nephrocalcinosis. So in intravenous pyelogram, you will see a brush-like appearance, which is the diagnostic entity of medullary sponge kidney disease, and you will tell the patient, please do not worry, ghar jao or so jao, because it has excellent prognosis. Because it has excellent prognosis. So you only get a brush-like appearance here. I hope I am clear, and I have discussed all the cystic kidney diseases also. I have discussed all the cystic kidney diseases also. Clear? Clear? I don't know what some of you are typing here. So with this, I have completed almost everything, and let me just give a check. I have completed the basics, the investigation, the symptomatology. In the systems, I have completed glomerular disease. I have completed acute kidney injury. I have completed CKD. I have completed the congenital glomerular diseases. I have completed the cystic diseases. I have completed the renovascular hypertension. Am I yes or am I true or am I wrong? Please correct me if I am wrong. Please correct me if I am wrong. I have completed all this along with anatomy, physiology, the investigation, the basics and whatnot. So what is left is only the electrolytes that I shall be teaching you tomorrow. Okay? Is it clear? Is it absolutely clear? Very good. Very, very good. I shall be teaching electrolytes tomorrow. Do not worry at all and do not panic. Do not worry and do not panic. Channelopathies I have also taught you. Tomorrow I will just give you a small table telling you the difference between the Bartter and the Gentleman syndrome, which many of you have asked me. In a very, very short format, I will tell you that also. I hope I am clear. Clear? Okay? Some of you have requested me cryoglobulinemia. Just give me 5 minutes. Chalo, I will not decline your request. I will not decline your request because you students have really kept up with me. So I will just, and I have talked to Arvind sir. He has taught you all the relevant points of diabetic nephropathy. So I will not take that up. Also Ranjit sir has taught you diabetic nephropathy, the pathology part and the clinical part sir has taught you. So I will not overlap that. That which is important and which has not been taught to you, let me just discuss that to you because you have been such kind students. Let me just discuss that. So, this topic is a very, at the onset you sound to be very difficult. Cryoglobulinemia, such a difficult topic like Wegener's granulomatosis. Now, of course, it is easy after Srinath sir has taught you. So, just I know, I told you, just everything is there in the name. Just break this and just convert it into simple terms. Cryoglobulinemia. Cryo means cold, globulin means antibody, emia means blood. So, globulin means antibody, cryo means cold and emia means blood. So can I say there are antibodies in the blood that love cold? Just see what have I done. I have just broken the word. Cryoglobulinemia means there are antibodies in the blood that love cold. So what are cryoglobulins? Cryoglobulins are those antibodies that love cold. Are you getting me? So please write down what are cryoglobulins. What are cryoglobulins? Cryoglobulins are antibodies that precipitate at temperature less than 37 degrees Celsius and redissolve on warming. So such a simple thing, sir. नेताजी सुभाष चंद्र बोस had said, तुम मुझे खून दो, मैं तुम्हें आजादी दूंगा. You give me blood, I shall give you independence. Cryoglobulins are such humble, such cute antibodies. They are telling you, you give me cold, मैं आ जाऊंगी. You give me heat, मैं चली जाऊंगी. If you give me cold, I will come to you. If you give me heat, I will give a bye-bye to you. I will bid adieu to you. Such cute antibodies and you were fearing this disease. So cryoglobulins are nothing but antibodies that can precipitate at temperature less than 37 degrees Celsius and redissolve on warming. Such cute, clear antibodies. So now, on the basis of presence of these cryoglobulins, we have classified cryoglobulinemia into 3 types, and that classification is known as Bruy classification. Sir, why have you told me the name? Because the year in which I appeared for my DNB entrance, though I did not take up DNB, but I had sat for the exam, that year this question had come. Bruy classification is used to classify dash. SLE, RA, cryoglobulinemia, PSGN. Answer is obviously cryoglobulinemia. Clear? So it is divided into type 1, type 2, type 3. Now just see, I will teach you a very easy format to learn this. Type 1, what does type 1 have? So what is the antibody in type 1 and what is the cause in type 1? Type 1 has a monoclonal IgM or a monoclonal IgG. In type 2, you have, now just see, as we will descend down, mono will become poly. But dekho, who will become poly first? That is the question, and that is a trick how to remember this. But how to remember, sir, in these two, in IgM and IgG, which antibody stays for long, sir? It is IgG. So, sir, which antibody has a right to become poly first, sir? Sir, जिसने ज़्यादा मेहनत की वो ज़्यादा पाएगा. Yes or no? You know, in that Super 30 movie, Hrithik Roshan had said what? Raja का बेटा राजा नहीं बनेगा. That who deserves will become first, becomes a Raja. So what will you say? Sir, that IgG has slogged his heart out. So, sir, let me make IgG poly first. So, mono will be, IgM will remain mono and IgG will become poly. But see the difference, it has become plus here, it was or here. And sir, in the last phase, everything will become hunky-dory and IgM will become polyclonal and this also will become polyclonal. Both have become polyclonal. So simple. So simple. Clear? If I ask you the cause, very easy, sir. Very, very easy, sir. Do you know of a disease where there are monoclonal antibodies? Of course, sir. I know only one. That is multiple myeloma. And there is also a disease which is a chachera bhai or the distant cousin of myeloma, which has a difficult name. Waldenstrom's macroglobulinemia. Waldenstrom's macroglobulinemia. Coming to type 2. Coming to type 2. What is the cause of type 2? Let me tell you, type 2 is the most common and that is caused by hepatitis C, hepatitis B and HIV. Hepatitis C, hepatitis B and HIV. Of course, the most common cause is hepatitis C. Hepatitis C. Very, very important. And last but not the least, the cause of type 3 cryoglobulinemia is autoimmune disorder like, sir, systemic lupus erythematosus, like Sjogren. And hepatitis C is so notorious that it can even cause type 3. It can even cause type 3. So a beautiful table has been made for you and very easy to remember. I think my stories will remain with you and you shall understand the 3 types of cryoglobulinemia. Now just see how many antibodies does type 1 have? Either IgM or IgG monoclonal, because it is an OR. Yes or no? That is why type 1 is known as simple cryoglobulinemia. But you see, type 2 has 2 antibodies, both IgM and IgG, monoclonal plus polyclonal or both polyclonal, yes or no? That is why type 2 and 3 is known as mixed cryoglobulinemia. You know, if you read Harrison, cryoglobulinemia is given in 2 different places. Part in nephro, part in rheumato. Yes or no? So what will you think? You will read and you will feel as if ki 1, 2, 3 is something else, simple and mixed is something else. But no beta, you have clearly understood today कि sir एक first का नाम ही simple है and second and third is only mixed. I hope I am absolutely clear. So if I ask you the most common type of cryoglobulinemia is of course type 2. If I ask you the most common association of cryoglobulinemia, I have highlighted it. It is of course hepatitis C. I always tell my students that, it's a trick to do MCQ. It's a trick to do MCQ. And whenever a question comes for vasculitis and the question says that the question is of a vasculitis and the person is hepatitis B positive, always the answer will be polyarteritis nodosa. And the person says, sir, iske hepatitis C positive hai, answer will be cryoglobulinemia unless proved otherwise. Just converts medicine into mathematics. This is the beauty. I always tell my students, this is how you convert medicine into mathematics. This is the beauty. So, when you have a lot of things to remember, long clinical questions will be asked, especially in MLE or MRCP, and not a person from Africa went to Australia to meet his sister. He was having joint pains. He was having weakness in his left lower limb. He was having hematuria, proteinuria. And one fine day, he was detected to have anti-HCV antibody in his blood. Which of the following vasculitis is he having? Arey boss, सीधा बोल, hepatitis C plus vasculitis. In options you see 4 vasculitis. आंख बंद करके, hepatitis C plus vasculitis is cryoglobulinemia. Hepatitis B plus vasculitis is polyarteritis nodosa. This is the answer unless proved otherwise. Clear? Clear? This is the beauty of solving medicine with mathematics. And quickly, how will this patient present? How will this patient present? Sir, this patient will have number 1, Raynaud's phenomena. Number 2, the Raynaud's can progress to gangrene. You must have studied in your systemic sclerosis the 2 types of Raynaud's. It's a type 2 Raynaud's, the secondary Raynaud's. So secondary Raynaud's progresses to gangrene like in systemic sclerosis, but primary Raynaud's is a self-limiting phenomena, does not have gangrene usually. Clear? The patient can have arthritis. The patient can develop mononeuritis, multiplex, that can cause weakness. So the patient can have arthritis, the patient can have mononeuritis multiplex, which can cause weakness, and the patient can have, because it's a small vessel vasculitis, the patient can have palpable purpura. And of course, in the kidneys, as I have already told you while I was teaching you MPGN, you will get an MPGN type of pattern. You will get an MPGN type of pattern. Is it clear? So basically, you get these clinical features. And you must have noticed that I have made these 3 points in 3 colors. That is a triad of arthritis, mononeuritis multiplex causing weakness, and palpable purpura, and this is known as Meltzer's triad. This is known as Meltzer's triad, which is also an MCQ which was asked before. So if I ask you, Meltzer's triad is seen in, answer is cryoglobulinemia. Cryoglobulinemia. I hope I am clear. Last thing, how will you investigate and how will you treat? Sir, the investigation will be, I will check for obviously the immune markers. I will check for immune markers and I will get hepatitis C positivity. I will get a rheumatoid factor can be positive, falsely positive. Rheumatoid factor का कोई ईमान धर्म नहीं है. Rheumatoid factor का कोई ईमान धर्म नहीं है. It is not a specific antibody. It's a sensitive antibody. There are some people, there's a trend that people post Facebook invites of weddings. Save the date. And there are some shameless people who save the date, they go to the wedding to have food. I hope you are not one of them. So rheumatoid factor is like that. Then there are some people who need WhatsApp message. Sir, WhatsApp karo tab aayenge. But there are some Swabhimani specific things which say, no sir, if you give me a phone call that please come, only my friend is getting married, then only I will go. So those people who are aswabhimani, non-respectful, who go with Facebook invites, those are sensitive, not specific. You will find them everywhere. Like rheumatoid factor, like ANA. Wherever there is inflammation, they will say, chalo, there is free ka food, let's go and dine. But there are some specific antibodies, like anti-CCP, like anti-Smith. What are they? They are specific. They have a lot of self-respect. They say, no, I will not go everywhere. Only when I am called upon. Only when I know that that is SLE ka inflammation, I will go there. That is why it's a specific antibody. Only when I know when the RA ka inflammation, I will go there. That is anti-CCP ka antibody. This is the beauty of sensitive antibody and specific antibody. Okay? I don't know too much of PSM. I don't know too much of PSM, but this is how I understand this. I hope I am clear. Clear, absolutely clear, and you will get compliments to be low and treatment. The treatment will be for if you have a hepatitis C associated or hepatitis C negative. How will you treat cryoglobulinemia? Just look for hepatitis C. Sir, if it's hepatitis C, give the patient antiviral therapy. If the patient is hepatitis C negative, give the patient steroid plus immunosuppressive therapy. Usually we give cyclophosphamide. This is the complete of cryoglobulinemia. Also, I have discussed that also, though I had no mood whatsoever to discuss this. This was not at all my plan. This was not at all my plan. Is it clear? I hope I am clear. Age of presentation beta is anything. There is no age of presentation. Cryoglobulinemia can present at any age. It can present at any age. With this, we have completed today's class. And I was showing you now this is the angiography. You can understand that what angiography finding is this. You are absolutely correct. You are absolutely correct that you have got a string of beads appearance, and this is a characteristic angiography of fibromuscular dysplasia. This is a fibromuscular dysplasia. Now don't ask me to teach the entire medicine. I don't know so much of medicine, okay? I'm a learner myself. I do not know so much of medicine. Clear? Now, this was about fibromuscular dysplasia, and this is though not my topic. This is though not my topic, but just to show you the contrast. This is just to show you the contrast. This is about fibromuscular dysplasia, and this is. Can you tell me this is the typical angiography of which? This is the typical angiographic finding of polyarteritis nodosa, and if you can see, there are some nodes here. There are some nodes like swellings due to inflammation. So basically the middle sized arteries, the middle arteries, the distal part of the renal arteries, they develop some node shaped swellings due to inflammations. And these are the node shaped swellings, and because they are node shaped, they are node like, that is why it is known as nodosa. So node ke jaisa, and if you can see, there is an abrupt cutoff of these renal arteries here. It just came here and there was no dye passing through here. So this is causing a renal artery stenosis, and this is typical of polyarteritis nodosa. This is polyarteritis nodosa, and yes, this is a microaneurysm. And in rare uncommon circumstances, this microaneurysm can rupture and cause hematuria, which usually polyarteritis nodosa does not cause hematuria. Clear? I have taught you this. We have discussed this. We have discussed this. We have discussed which is the best nutritional regimen. You are absolutely correct. Sir, high calorie and low volume. We will not give low calorie, low volume. High volume to definitely not. Low volume, high calorie. I'm so sorry. The answer is high calorie and low volume and not this. Clear? We have discussed this also. We have discussed the GCA. Now tell me this one. What is the most common cause of intradialytic hypotension? Intradialytic hypotension. Intradialytic hypotension, is it sepsis? Is it cardiac ischemia? No sir, it is intravascular volume depletion because of excess fluid removal. So you remove excess fluid from the body, you basically removed more than the patient could sustain. So you have intradialytic hypotension. The immediate treatment is stop dialysis. Obviously make the patient lie down and give IV fluids to the patient. And give IV fluids to the patient. And just before ending, I will just take 2 more minutes, and that is because of a very interesting message I got from a guy. I got from a guy who's from Delhi, a very good college from Delhi. I will not say the name and the name of the college. What happened was, he messaged me yesterday and he told me, sir, I have read SLE completely from Harrison. Sir, is it complete, sir? Sir, is it complete, sir? Is it enough to read SLE from Harrison, sir? He is absolutely correct. He is absolutely correct in all his humility, in all his naivety. He told me this and he asked this. I said yes. But then I was thinking to myself that is a book, is SLE, is Harrison, or even if is even Kelly's textbook of rheumatology enough to teach you a disease like SLE? And I thought to myself, at least I have read both, but still I do not know SLE. Let me tell you, I do not know SLE, and every time in life I have thought that I know SLE, SLE has challenged me. SLE has given me wonders. It has given me reality checks. Rheumatology is such a subject. Just to tell you a short story, what happened with me was, I was in my first year of internal medicine, and I had read the SLE criteria thoroughly. I was sitting in a busy OPD, a medicine OPD, and the person came and a young girl, and we in undergraduation we used to think rheumatology is equal to SLE and SLE is equal to malar rash. I had just completed, MD entrance examination, entered first year MD medicine. So I was very, very enthusiastic. I entered the OPD. I was sitting in a busy OPD, and suddenly a young girl came to me, and she told me, sir, I have fever, I have joint pain. When I raised up my eyes, I saw there was a malar rash. So I wrote on my prescription, fever, joint pain, malar rash, diagnosis, SLE. And to flaunt my knowledge, I went to my guide, I went to my sir, and I told him, sir, this is a female with fever, joint pain, malar rash, sir. Sir, this is an SLE. No differential diagnosis. Straight away provisional. So much of confidence, bursting with confidence, New medicine PG resident just crossed All India with a good rank. So I was bursting with confidence. I told, sir, I'm ordering an ANA profile, sir. I'm ordering ANA, sir. Sir said, Vivek, why do you say it's an SLE? Sir, she's a young female, sir. She has fever, sir. She has joint pain, sir. And sir, she has malar rash. I was bursting with enthusiasm. And sir, she also has oral ulcers, sir. I've written, sir. And sir, in the criteria also there was all this mentioned, sir. Just a second. What did you say? She has oral ulcers. How do you know that she has oral ulcers? Sir, she is sitting in front of you, sir. Please ask, sir. Ma'am, do you have oral ulcer? See, sir. Sir told me, Vivek, have you read the criteria properly? Have you read the theory properly? Please go and read there. It is painless oral ulcer. So if an oral ulcer is painless, how can she come herself and complain you that I have oral ulcers? So that day I learned that an SLE patient does not come and complain you of oral ulcers. You have to look with a torch in the hard palate and look into her mouth and look for oral ulcers. So I got a big reality check. All my enthusiasm went down. And ultimately I understood that I am just overconfident without knowing anything. I again went to the OPD. 1 month later, I was again sitting in a busy medicine OPD. I was doing my work and a young girl again came. She told me, sir, I have fever, I have malar rash. And I have fever, I have joint pain. As soon as I checked, she had a malar rash. And now, I told her, don't speak anything. Just wait, just wait. I myself took the torch and I was looking into her mouth and she said, sir, kya dekh rahe ho? I have an oral ulcer. I said, fish man, why do you say this? So I wrote on my prescription, fever, joint pain, malar rash, painful oral ulcer. And then I took the rest of the history, anemia, pleural effusion, whatever. And now my confidence was shattered. So now I did not write any diagnosis. And I went to my mentor, sir, this is the case, please help me, sir. Sir asked me, Vivek, what do you think? I stood mum like a stupid fellow. Sir said, sir, what is your presentation? I said, sir, she has a fever, she has a malar rash, she has a painful oral ulcer, she has joint pain and she has all these things. Sir said, Vivek, are you not thinking of something? I thought sir is leading me into calling SLE. I thought sir is laying a trap. I stood there mum. Sir said, Vivek, tell at least one diagnosis. I thought sir is leading me further. Sir is acting over smart. I will not speak anything. I said, stood there mum like a utterly stupid fellow. Sir said, Vivek, are you not thinking of SLE? I said, sir, you only told me last month, sir, that SLE has painless oral ulcers and this patient has painful oral ulcers. How can it be SLE, sir? Sir smiled at me and sir told, Vivek, you do one thing, you come to me when the OPD comes with this patient again. Right now it's a busy OPD, we will discuss it later. I was waiting the clock to strike 3:30 when the OPD gets over. As soon as the OPD got over, I told the female, I had made her sit, I had arranged tea and snacks for her. Ki boss, aap jana mat. Ma'am, you please go, don't leave. When the OPD got over, I immediately, when sir was leaving, I said, sir, please help sir. Sir said, Vivek, what is hindering you from thinking of SLE? It's a telltale evidence. I said, sir, but she has painful oral ulcers. Sir again smiled with all his humility and sir told me, Vivek, what resides in your mouth in millions that you keep munching day in and day out? I said, sir, bacteria. And sir said, can't a painless ulcer of SLE get infected? And will a infected ulcer not have pain? I was like, in my head I was thinking, sir, aap head bhi le lo, aap tail bhi le lo, sir, what is this? So that day I learnt a new lesson that SLE ulcers per se are painless, but if it gets secondarily infected, it can be painful. So, again my confidence got shattered and I was like learning the lessons of life. So, I went back home, I again had to fight the criteria of SLE again and again and again. That day was engraved in my mind and I was, waiting that one day I will go and tell to sir that no, I know something. So now what I did, I acted over smart. What I did was, I downloaded the criteria and took a screenshot of the SLE criteria. I thought, now to मैं Harrison खोल के patient देखूंगा. Now you come, now you defeat me, how will you do? So I was sitting in a busy medicine OPD 2 to 3 months late. Again, a young female came. I was writing something. She said, sir, I have fever. I said, okay. Sir, I have joint pain. Sir, I have something. And there was what? There was my favorite malar rash. And now I told her, ma'am, don't say anything. You keep shut. She did not speak anything. I took her mobile torch and looked into her mouth. Thankfully, there was ulcer and she did not complain. So I wrote on my prescription, fever, malar rash, painless oral ulcer, joint pain. And now what I did, I took the criteria, the older criteria, the 11 and 7 criteria, and I took it and I was trying to tick it. I wrote anemia, present, pallor, yes, present. Pleural effusion, yes. Proteinuria, reports, yes. ANA, like this. So I was taking it. So I took pleural effusion, yes. Anemia, yes. Pericardial effusion, no. Proteinuria, yes. Alopecia, yes. I wrote everything. Now I wrote provisional diagnosis SLE. Plan blood for ANA and ANA profile. I wrote this and C3, C4. So now I thought, now I will at least attain nirvana and now I will prove my mettle to my teacher. So now I went to sir and now my tone was absolutely mellowed down. I was no longer that, because in 4 or 5 months my enthusiasm was there, but my confidence had broken to pieces. Because I understood कि theory में कुछ gene और chromosome को याद करने से I will not learn medicine. Medicine is only learned by seeing patients. So now I went to sir. I said, sir, Sir, I have a patient who is a 23-year-old female. Sir, she has a fever, she has joint pain, she has painless oral ulcers. I did not do this, I said this in the mind. Sir, she has, on examination, she has pleural effusion, sir. Sir, in the report, sir, there is a proteinuria which is more than 500 milligrams, sir. Sir, she has an old report in ANA which is positive in more than 1:60 titer, sir. And sir, she has alopecia. Sir, she has it. Sir said, what do you say? Sir, she has alopecia. Sir, Vivek, how do you know that she has alopecia? I said, sir, the female is sitting in front of you. Sir, ma'am, you have alopecia? He said, yes. Sir again smiled. He said, now, in my mind I was thinking, now what happened? Sir told me, Vivek, do you know of any female Homo sapien on this earth, which if you ask her, she will say that she does not have hair fall? I did what in my mind? I said, what is this? Sir said, Vivek, you never ask a female about hair fall because everybody will say yes. You take a torch and look into your scalp yourself. I was like, God, somebody help me, koi utha lo mujhe. That day I learned a new lesson that you do not ask for hair fall. You straight away examine yourself. So that was the day and today is the day. I have come a long way, but trust me, I have never ever gathered the courage to tell to myself or to the other person that I know rheumatoid, I know SLE for sure. SLE is that big a diagnosis because SLE patient, I have read Kelly's, I have read Brenner's, I have read Harrison, I have read the guidelines, what not. But every time SLE patient comes to me with a new googly and she gives me a new management thing because she asks me petty things, sir, can I get pregnant, sir? Sir, can I conceive? I mean, on the immunosuppressants, because you cannot give her immunosuppressants and let her conceive. If you give them off, she will have a flare. And these are the practical problems, what to eat and all that jazz. Many things are not even there in the books, only learned by seeing patients. So, that was just a small story I shared with you. So, that's all for today. Tomorrow is the last day. I'll see you and I would like to end, or maybe beginning of a new ending or whatever that is called, that the only thing standing between you and your goal is the bullshit story that you keep telling yourself that why you can't achieve it. So please stop bluffing yourself. Please don't tell yourself that I have limited resources, I belong to a small town, I belong to a private college, I belong to a periphery college, I started late, I started an internship, I don't have this resource, I don't have a latest laptop, I don't have that notes, this teacher taught me. All bullshit. If you want it, if you work hard, nobody on this planet can stop you, man. Nobody. Who is anyone to stop you? Who is that you can be rank 1 in whichever exam you want to? It is the lack of your decision making that is hindering you. Please make that decision today. Step up your pedal, pull the 5th gear and take it to the exam, because trust me, this will determine your entire life. Am I clear? And quickly I wish to see you with your success stories, and I want you to be interviewed by Sumer sir and other faculties, and I want to view that video, and one day I want to tell everyone that this was my student and he is somewhere here. And we shall be colleagues and we shall be working together, and some of you might be joining nephrology in future, so we shall be working together, we shall be doing renal transplants and writing research papers also. Okay, so please do it. Thank you very much. And I would like to leave you with a very famous and very, very favorite song of mine, and with the favoritist song of mine, which I used to hear daily during my MD preparation. The song is Ashaएं from the movie Iqbal, and I love this paragraph, and which reads, कुछ ऐसा करके दिखा, खुद खुश हो जाए खुदा, आशाएं खिले दिल की, उम्मीदें हंसे दिल की, अब मुश्किल कुछ भी नहीं, कुछ भी नहीं, कुछ भी. So are you ready to do something that can please the God? कुछ ऐसा करके दिखा, खुद खुश हो जाए खुदा. I have, lived my life, and I want to live my rest of my life with these 2 lines daily telling to me every day. Thank you very much. It has been a pleasure. Tomorrow will be the last day. We'll again try to end on a high note. Please follow me on my social media accounts. Wherever you want to ask me whatever you want to, follow my page, follow my YouTube channel. Thank you very much. Shabba khair. Good night. Love you all.